Liver cirrhosis, or end-stage liver disease, is extensive degeneration and destruction of liver cells. It also is replacement of liver tissue by fibrous and or regenerative nodules. This usually happens after decades of chronic liver disease. The most common cause is alcohol-induced and or hepatitis C. Other causes include extreme dieting, malabsorption, obesity, and genetic predispositions. Biliary cirrhosis and or cardiac cirrhosis from long-standing severe right-sided heart failure specifically is related to cardiac cirrhosis. But remember, the most common cause is alcohol-induced and hepatitis C. Again, in order to fully understand the disease process, we need to understand the functions of the liver. There are many, and that is time for another lecture. But to name a few, liver creates bile. It assists with clotting factors, such as vitamin K, which can lead to bleeding disorders. It stores glycogen, it stores fat, and it also helps with metabolizing food and drugs. So these are all important to understand as we go through the manifestations and treatment. Some objective data you might find when looking at a patient with cirrhosis is anemia, thrombocytopenia, and leukopenia, as well as decreased serum albumin and potassium levels, abnormal liver function studies, increased INR, and increased ammonia and bilirubin levels. A lot of these have to do with those functions that we just spoke about. So as you go through each one of those objective data, I'd like you to ask yourself why and try to go back and figure out the reason connected to the function of the liver to truly understand what is happening instead of just memorizing the facts. I've added the normal lab values as well as what typically will increase and or decrease with cirrhosis. These levels are important to keep in mind because I have a feeling they might show up on our exam. Specifically mentioned in a lecture was ammonia, PT, INR. Actually, everything with the low or increase next to it is something I took note of. So I pay special attention to those levels and again, have a basic understanding of why. Early clinical manifestations, however, are very few. There are very limited symptoms in the early stage of the disease. The patient may experience some fatigue and or have an enlarged liver. These are typically all you'll see in the early in the early stages. Blood tests are even typically normal during this time due to the compensation of what is called compensated cirrhosis. Late manifestations of liver cirrhosis result from liver failure and portal hypertension. This can include jaundice, which can be minimal to severe, peripheral edema, and ascites. So the main three late manifestations are jaundice, edema, and ascites. Jaundice is due to the decreased ability to conjugate and excrete bilirubin, as well as the overgrowth of connective tissue in the liver, which compresses the bile ducts, which this can lead to obstruction and increase the bilirubin in the vascular system. The portal hypertension is due to the increased venous pressure in the portal circulation. This can cause ascites, splenomegaly, large collateral veins, and most important sign to remember when you think of cirrhosis is gastric and or esophageal varices. This is because there is a huge risk for bleeding. They are very fragile and life-threatening complication. And again, they are collateral veins, which can bleed very easily. So this is a complication, and we want to treat this by preventing bleeding or hemorrhage of these varices. And the most important teaching is to tell your patient to avoid alcohol, aspirins, and any NSAIDs. You also want to treat hypertension and keep the blood pressure at a lower level so that we aren't creating too much pressure inside of those collateral varices, which would increase the chance of hemorrhage. The priority in nursing intervention for this patient is likely going to be to maintain the airway. So it's important to keep suction at the bed. If bleeding occurs, stabilize the patient, maintain the airway. Again, your priority, if bleeding occurs, is to maintain the airway and prevent obstruction. You can also provide IV therapy of blood products, such as octreotide or vasopressin are two medications that would be given. For active bleeding, there is some therapies that can be used. The balloon tamponade is going to be for an active bleed, and it's an invasive procedure that involves taking a deflated balloon and inflating it to put pressure on that varices to stop the bleeding, and it is important to keep scissors at the bedside. It creates a mechanical compression of the varices. Other endoscopic therapies could include band ligation or sclerotherapy. The third late manifestation we mentioned earlier was ascites, and ascites is the accumulation of serous fluid in the peritoneal cavity. There are three specific mechanisms that cause this ascites, one being portal hypertension, two being low albumin, and three increased aldosterone levels. In order to treat ascites, we want to make sure our patient is on a sodium restriction. You can also provide albumin and diuretics. Tolvaptan or Samska is another medication given. A paracentesis is sometimes done for ascites. You want to make sure to position the patient on the right side. A TIPS and or a peritoneal shunt is other treatments for ascites. Dyspnea is common due to the increased fluid in the cavity, putting pressure on the lungs, making it difficult for the patient to breathe effectively, as well as often hearing crackles in the lungs. So with dyspnea, we want to make sure to position the patient in a high Fowler's position to relieve the pressure on the diaphragm. Here is a little map explaining the pathophysiology behind ascites and how it's related to cirrhosis via the mechanisms I just explained. This just goes a little bit further, explaining how the liver failure can cause the decrease in albumin and decreased capillary oncotic pressure, which then causes that leakage of plasma out of the vascular space, which contributes to the ascites, as well as the portal hypertension, which increases capillary filtration pressure and contributes to the ascites, as well as increased lymph production, which causes dilation of lymph channels draining to the liver, and leakage of lymph into the abdominal cavity, which also contributes to the ascites. So you can see how there's a lot of mechanisms that all contribute to that ascites in the patient. Since the liver is responsible for clotting, there's also some hematologic disorders that we've kind of brushed upon. So thrombocytopenia, which increases the risk for bleeding, and also changes the MI injection fraction, meaning the amount of blood ejected from the heart. Leukopenia, anemia, and coagulation disorders, and that low vitamin K due to the liver dysfunction. There's also some peripheral neuropathies, such as dietary deficiencies of thiamine, folic acid, and B12. This can cause sensory and motor symptoms. Skin lesions, increasing circulating estrogen from the inability of the liver to metabolize steroid hormones can cause spider angiomas and palmar erythema. Peripheral edema is due to that decreased colloidal oncotic pressure from the impaired synthesis of albumin. And that results from the increased portal pressure from portal hypertension. And then there's also some endocrine disturbances, especially with males. Gynecomastia is common, or like man boobs. This is secondary to decrease in metabolism of hormones. Females can exhibit loss of pubic hair, and males as well as that, and testicular atrophy and loss of libido. Females typically have amenorrhea or vaginal bleeding, and hyperaldosterone is common with both sexes. When you think of cirrhosis, I want you to think of hepatic encephalopathy. This is a huge one related, which is due to the buildup of ammonia. And this can cause neurotoxic effects and abnormal neural transmission. And ammonia actually crosses the blood-brain barrier because the liver is unable to convert it into urea as it typically would and excrete it. This causes changes in neuromental responsiveness, impaired consciousness, inappropriate behavior, sleep disturbances, trouble concentrating, and worst of all, astrexia. If a patient is having flapping or tremors, you're going to have them, or even if they're not, you're going to ask the patient to hold their hands out and check if they're having any flapping or hand tremors, impaired writing, difficulty moving the pen left to right. This can all be an indication of hepatic encephalopathy, which is a very dangerous condition, and lactulose needs to be given immediately to reduce the ammonia formation. Lactulose is a laxative that will cause diarrhea. It will bind with the excess ammonia and be excreted. We also would like to treat the precipitating factor or cause, which would be to lower protein intake, control GI bleeds, or remove blood from the GI tract using a NG tube. To review the pathophysiology of cirrhosis in a nutshell, chronic liver inflammation due to hepatitis and or excessive alcohol intake leads to liver necrosis. This liver necrosis leads to liver fibrosis and scarring, which increases portal hypertension, which can cause ascites, edema, splenomegaly, and results in anemia, thrombocytopenia, leukopenia, and causes varices, either esophageal or gastric, hemorrhoids, and or superficial abdominal veins due to that collateral circulation. The liver necrosis causes a decrease in bilirubin metabolism, which causes an increase in bilirubin in the blood, which manifests as jaundice or the yellowing of the skin. The decreased bile in the GI tract results in light-colored stools, and you want to remember that cirrhosis is associated with light-colored stools. We also talked about that vitamin K absorption, which is decreased due to the liver necrosis, which can increase bleeding tendencies. And the increase in bilirubin in urine manifests as dark amber urine. Another effect of that liver necrosis is the decreased metabolism of carbohydrates, proteins, and fats. This can result in hypoglycemia. So we want to monitor blood sugars. This can also result in decreased plasma proteins, which also affect that fluid volume shift and can contribute to ascites and edema in the patient. Another effect of this liver necrosis is altered hormone metabolism. We touched on this earlier. In males, it can cause testicular atrophy. It causes an increase in androgens and estrogens, which manifests as gynecomastia, loss of body hair, menstrual dysfunction, spider angiomas, that palmar erythema or red palms, and increased ADH and aldosterone, which also contributes to that edema in the patient. All of this resulting from liver necrosis will show in the lab values by increased AST, increased ALT, increased alkaline phosphatase, increase in bilirubin, and longer prothrombin time due to that bleeding tendency, and the decreased vitamin K absorption, and a decrease in albumin. All of this contributes to liver failure, which can manifest as hepatic encephalopathy, which is a late sign of liver cirrhosis. And remember those neurological changes that happened. That is hepatic encephalopathy, which will likely result in a coma and lead to death for the patient. These patients it is a chronic disease. They are not going to live. It is going to progress eventually to death. And the best thing we can do is care for these patients and treat the symptoms. Liver cirrhosis
So that is that. And I want to remind you guys again, I am human. There may be mistakes. However, I have done my best to compile a good information for the exams in regards to liver cirrhosis. And hopefully it's a pretty complete picture of what we need to know. And I hope you've learned something from this and can take it with you on your exams.